Wonderful. Good morning, everyone. It is February 25th and the beginning of our CROI review series. And we have one of our fellows who attended CROI, not for the first time, I don't believe. I'm looking at Katie to see if it was not your first time, right?
It was my first official time.
Okay, so your first official time, and then I very quickly said, and you're going to report back to us on NeuroHIV, which Katie graciously did. So this will be a review of as much of the NeuroHIV as Katie can give. But let me introduce Dr. Patricia Katie Riggs, and she goes by Katie unless something has changed. Katie completed her undergraduate degree at University of California, San Diego in biology. She then joined the U.S. Peace Corps, where she served as a community health educator for 2 years in Tala, Eastern Province, Kenya, with a focus on HIV/AIDS. She returned to San Diego and worked as a research assistant and clinical trials coordinator at UCSD's HNRP, which solidified her goal to become a physician to allow her to be a future research investigator and provide individual patient care. She went on to medical school at Kansas City University of Medicine and Biosciences, College of Osteopathic Medicine. After graduation, she completed residency in internal medicine at Scripps Mercy Hospital. Dr. Riggs returned to UCSD in 2020 to pursue training and ID fellowship. In addition to the clinical training, she's pursuing research in the mechanisms of neuropsychiatric sequelae of HIV and other viral infections, with particular interest in the role of immune activation and dysregulation. So we are really excited and pleased to turn it over to Katie. The poll that I mentioned very quickly is we're going to do another poll probably next week about returning in person versus being away versus some sort of hybrid. And we just want to get people's thoughts again, since the last time we did it was a few months ago. Anyway, Katie, I'll be monitoring the chat for you and we'll only interrupt for clarifications. We'll try to save, I'll give you a 15 minutes warning. Turning it over to you.
Yes, definitely. Okay, there are chats, questions.
I think you might be freezing a little bit, unless it's on my side. Yeah.
Great. Now?
Yeah, I mean, it was freezing.
Sure.
I hate having you turn off your video since I think it's really nice, but I don't know if that will help. Yeah, you're frozen, Katie.
Anyone? Anyone?
Now we can hear you, but I just turned your video off.
Okay.
So maybe, and now you're in a different view. So okay, do your view again.
Okay. I switched internet, so hopefully this one will be
okay. Well, and I
better.
can also, I can do your video again.
We can
forego it.
Yeah.
Okay.
Okay.
Go ahead, Katie.
So let's do this. So this is hot off the presses. We do have it officially ended yesterday. So this is as much of the NeuroHIV as I can pack into this. I did rearrange it. So we are talking about the most clinically relevant, practice relevant stuff first, so I don't get too in the weeds to start off. So first, for the overview, we're going to talk about treatment issues first. We're going to, and I gave you a little heads up of kind of I think the biggest messages are kind of optimization is better than intensification, and INSTIs and the 2-drug regimens seem to be pulling ahead or staying ahead. And then we'll talk about some diagnostic and prognostic measures, and then we'll get into the pathophysiology and especially talking about the CNS reservoir and the macrophage versus T cell debate, which was a hot debate. And key themes, this is kind of odd, but just keeping in the things that I came away with after CROI was to remember that everything's more complex than we initially think it is, which is why everything ends in more research is needed. And that the word system means a lot to me and should mean a lot to us. That the immune system is called a system for a reason, and we can't really simplify it. And the same for the, am I still?
You're good.
Okay, for some reason, everybody's videos just disappeared.
Oh, no, you're good.
All right, cool. And then same for central nervous system, we lump it all together, but there are individual critical components. And as everyone knows, there's heterogeneity within the population at every level. So jumping right in. So to start off, it's with what you could call a negative trial, but it is informative for sure. So, and I'm not just starting off with it because my mentor, Dr. Latender, presented this, but I think it does have significant meaning for us. So this was ACTG 5324, so randomized trial of ART intensification for cognitive impairment in people with HIV. So it was a randomized double-blind placebo-controlled trial, and it was in the US and international sites. Overall, the reason behind it was to see if intensification and specifically adding dolutegravir or dolutegravir and maraviroc would improve cognition. So we would be in this box here of if you would add drugs to the existing regimen instead of changing the regimen. And so it was measuring neuropsychological performance, and that was the outcome. So eligibility, they couldn't be taking an integrase inhibitor or maraviroc, and they had to be virally suppressed on their current regimen. And they were at least one standard deviation below the mean on 2 different domains for neuropsych testing. And no other obvious cause of impairment, no TBIs or severe psychiatric disease. So they were continued on their current ART and then randomized to either add dolutegravir and maraviroc, dolutegravir in a placebo, or dual placebo. And they had NP neuropsych testing at weeks 24, 48, 72, and 96. And the primary outcome was week 48 with change from baseline on their neuropsych scores. Basically, the demographic table and disease characteristics, it was actually remarkably well matched. So that's the main message here. Safety was very well tolerated. The purple here is the dolutegravir and maraviroc arm. But if you notice on the left side, this is very, very small proportions overall. So it's ended up not being a significant difference there. And one thing is relevant for a later talk as well, that it was not statistically significant, so we won't read too much into it, but there for people who were on the dual placebo, who remained on their prior suppressive ART, they did over the course of this trial develop, or 4 of them, so 6% developed confirmed virologic failure, which could raise the question with additional data down the road of whether it needed to be just optimized or intensified. And so results, primary and secondary outcomes. So overall, the total Z-score for neuropsych testing across all domains improved, which is exactly what we would expect due to the learning effect. There was no compensation for that. And there was no difference between any of the groups for that. And then the BDI and the PHQ-9 improved over time, but it didn't really matter or differ significantly from the groups. And I think the biggest thing is maybe enrolling in a trial is beneficial because the first visit is decreased in all groups. So overall, I already said most of this, but intensification didn't alter neuropsych performance. So basically, the takeaway is that there's no role for empiric intensification or just adding medications to try to improve cognitive impairment. And so then another talk was from Dr. Mastarosa and from Italy. And she was talking about the declining prevalence of hand and if there's a role for novel ART regimens. So overall, it was good news, and it is consistent with other data as well, that over time, starting in 2009, they broke it down into 2 to 3 year segments and noted significant improvement or decrease in rates of all levels of neurocognitive impairment, and down to 22%. And the interesting part is, I do apologize for the complaining and not complaining terms. I would not necessarily term that, we'll call it symptomatic. But it is interesting to note that we should really listen to our patients, and that of the patients who reported either attention, memory, or other cognitive issues, they were much more likely to be diagnosed with some form of hand. And then, so I kind of glanced over how much it was the overall rates were improving, mostly because they didn't account for learning effect. And it looks like most people had at least 2 visits over this span of time. So it's not real clear about what the rates really were and how much they really improved, but we do know they are improving with our better ART and our better regimen or treatment rollout and our better suppression. So, but there were interesting parts for sure. So the type of ART regimen was significant, and it was really the NRTI and INSTI combination as well as dual therapy that came out on top. So these are the adjusted odds ratios, all compared to basically a tripla or an NRTI and an NRTI base. And PIs did not really do anything over, and if anything, it's not significant, but if anything, they were a little bit worse than the NNRTI. And then here you can see the adjusted odds ratios for increasing years, and got an odds ratio of 0.43 for the years 2018 to 2020, which is quite dramatic and awesome. But we don't know exactly what the rate is. And it does seem like a lot of that is due to increased INSTIs and some dual therapy, as well as viral suppression in our populations. And yeah, most significant. For the symptomatic people, you have an odds ratio almost of 4 to actually have cognitive issues. So listen. And then I thought one thing that was good news, that there was something we can do, which it seems like exercise always is that thing, that is positive in the literature. And this was another one. And it was actually a pretty interesting study, because they got around not having a control group in a pretty interesting way. And convincing. So they took 30 people with HIV, all in the older category, that was in quotes, at greater than 50. They were sedentary at baseline, all were virally suppressed. And then they gave them a trainer and time at a gym 3 times a week. And they had what they did is then at 6, they imaged and they did neuropsych testing at baseline and then again at 6 months. And they measured the increase in physical strength on 4 different exercises. And the most significant one was the lat pull, which correlated with executive function, brain volumes, and decreased inflammation. So this was basically, it's just correlation of the people who, everyone got the intervention, everyone has HIV, but the people who increased their strength the most and also benefited in these other areas more. So this is on the right here, we've got percent change in the lat pull down, 1 RM, which is basically 1 repetition maximum. This was, I'm not in exercise research, so this was unfamiliar to me, but basically the maximum weight that you can do once. So, and then this is the change in frontal lobe volume. So over 6 months, they increased in strength and their frontal lobe volume on MRI actually changed. And they did have decreasing soluble CD14, which has been associated with cognitive impairment, especially in HIV positive people, and is technically a marker of monocyte activation. So not necessarily your typical go-to first marker of inflammation, but it is a valuable one and did decrease significantly. So I think that overall it was interesting design. I don't know if it suggests that the people who really invested and put more effort into the sessions benefited most, or if it's the people who were already had the capacity to build muscle and get stronger were the ones who also improved in these other ways. But I think it's encouraging, and we could always use some encouraging news. It is a little bit meh because it was, it's expensive. So this isn't telling your patient to, go walk around the block 3 times every day. And we don't know how that correlates to going to the gym with a trainer 3 times a week, but it's a start.
Katie, I'm fascinated by this study, the fact that and I hope that no one on here was part of the funding. I mean, it's great and it's interesting. It's completely not something that's translatable to the real world. So it's funny to me in some ways. I mean, maybe we can take some of these principles away, but 6 months, 3 times a week with a trainer?
Yeah.
Wow.
But Jill, Jill, I wonder,
Yeah.
because I was just thinking about with the trainer, I mean, I wonder if that's translatable to, the social interaction aspect as well. And so
True.
maybe if they sign up and do Zumba 3 times a week or something.
Well, then study
Although
that.
I have to tell you,
They
I'm
should
gonna
have
start
studied
doing
that.
lap pulls.
This is so
Well,
expensive. I don't know
No,
how
but it's
you.
a proof of it's a proof of
Yeah.
concept.
I think
and
I would have
it's-
started. I would have aimed lower to begin with, but I may be someone in the. See, wouldn't it be great to have a trainer and fitness coach at home? We can't.
Well,
Oh, sorry. Maybe I'm
So
just becoming a
Medicaid
little
should pay
jaded.
for a trainer 3 times
Yes.
a week.
Okay, good. Sorry to interrupt, Katie. Very
Yes,
interesting.
no, that's the next step, I'm sure, is
Yeah.
trainers for everyone. But I think it is still encouraging to tell our patients that if you do enough exercise 3 times a week to over time build up your strength, and they did combine cardiovascular as well, or cardio as well as the strengthening measures.
Start doing lap pulls.
Yeah. So, but you can change your brain. So that's cool. And then for diagnostic and prognostic measures. So this was from our own Dr. Ellis, and this is from Charter data as well. So a novel comorbidity index predicts cognitive change in people with chronic HIV. So basically looking at the data, looked at the comorbidities that were best at predicting future neurocognitive performance. So this is Charter, which was, so we have the baseline, which was 12 years prior, and then Charter aging brought people back 12 years later. And so we're comparing over a period of 12 years, which we don't often get in studies. So basically it came down to 3 comorbidities, which is pretty simple. 1 point per comorbidity. So maximum 3 points, minimum 0 points. And the 3 things that came out were hypertension, chronic pulmonary disease, sorry, not necessarily obstructive disease, but just chronic pulmonary disease, and BDI greater than 13. And so
Greater than 13?
BDI, Beck depression.
Oh, sorry.
Yeah.
Sorry.
And then the largest effect was for COPD, which seemed surprising to me, but actually it holds up, and it's not the first time in the literature. It certainly has come up in Charter multiple times, and there's a very strong signal for lung disease correlating with future neurocognitive impairment, and that's what we saw here. And that, interestingly, and most convincingly, this simple 3-part comorbidity index was significantly associated with neurocognitive worsening over 12 years. And when you put it into models with other risk indices like Charlson, the VAX, the Framingham, the SCI did better, and it was the only one that was significant. So you can kind of see the stepwise progression here. So note that worse is going up. So the axis has kind of been flipped here. So this is 0, and then as you go down on your score, goes up. So 2 plus comorbidities, you basically don't go down half a point here. So it's significant, it's easy, it's not necessarily, it doesn't spit out a percentage point for you of risk, and it doesn't necessarily, we weren't able to tease out whether treating the hypertension successfully alters this. We just didn't have enough granularity in the data and enough time points to really measure that. And so that brings us to the next part, which is not from CROI, but what I wanted to just bring up quickly, because this is CNS Biotypes is, sounds like one of the big hip terms that you will be hearing more and more in the future if you haven't already. And that this is basically acknowledging and coming up with a potential solution to what we've known forever is people with hand are not all the same. And because they're not all the same, they probably, even if they have the same score and the same deficits in the same domains, they may have underlying conditions and the pathophysiology is actually different. So instead of just characterizing them and grouping people by what we can measure, this is basically doing machine learning. So taking as much data as we can, all of the drug history, the neuroimaging, the neuromedical history, and by drug, I mean both substance and medication use, and adding biomarkers. You can kind of add everything. And with machine learning, you don't have to worry about multiple comparisons. I can't actually speak to why that is yet. I've not gotten to that point in my biostatistics, but it is true. I've been told. So then you have this heterogeneous cohort with varying symptoms and varying cognitive impairment. With all of this additional data, then it should be able to spit out basically different phenotypes that speaks to the underlying pathology and their symptoms and signs. So that was a little bit of a sidetrack, but you will be seeing a lot of it. And the last Thursday, right after, or right in the middle of CROI, I guess, was a day-long NIMH seminar on the CNS biotypes, which was the second one this year. So it's a thing. And part of this one, or I guess not necessarily part of that, but the from Charter, there was machine learning and this phenotyping done from polypharmacy and from drug or medication prescriptions. So what they did is they put in all of the different non-ART medications that people were on and put it into a model, and it came out with these 7 different profiles. Profile 1 is not impaired. And then these are all, I'm not going to go through each one, but basically they're different patterns of cognitive impairment, and they correlated with different groupings of medications. So they weren't perfectly grouped on CNS agents or antimicrobials. It specifically grouped it based on these profiles, but they are named here for what was the most prominent type of medications in those clusters. And overall, this doesn't necessarily tell us anything, at least to my knowledge, of what we're going to do in the clinic tomorrow, but the meaning and the promise of it is that this may point to polypharmacy and what the true impact of different medications are on cognition. Initially, when I saw it, I had apparently the same thought that many people did, because it was all over the chat for their poster, was, well, yeah, people are on certain medications for a reason. And so how can you separate out what their underlying condition is actually contributing? And what they found was, of course, they don't have all the comorbidities and they don't have all of the actual indications for each medication. But when they do put in the comorbidities, these groups of medication, of prescriptions, were stronger at predicting these profiles, these cognitive profiles, than any of the comorbidities or underlying diseases. So hopefully down the road, it will give us meaningful clinical information on which medications really are impacting cognition and in what way. And that is what I can say about that one. And then this one I could talk about for a long time because it's mine. But and somehow I even took my name off of it, but it's mine from CROI.
Hey, you can't do that, Katie. You got to give yourself the credit.
I know.
All right,
My
next time.
goodness. Maybe I should put it in disclosures, but I have a poster. So this was high protein carbonyl levels correlate with abnormal white matter in people with HIV. So basically, people with HIV, we do know there's higher rates of cognitive impairment, there's higher oxidative stress, there's higher white matter hyperintensity or abnormalities. And so this was also part of the charter aging. This was cross-sectional analysis of people who had both biomarkers done in blood and MRI. And a subset of those people, so there were 55 total, and then 35 of those had CSF as well. And so overall, we looked at the biomarkers, and the panel included markers of typical inflammation, neurodegeneration, and then a couple markers of oxidative stress, of which protein carbonyl is one. And it was the only, protein carbonyl was the only one that significantly correlated with anything that remained significant in multivariate models. NFL and tau in the CSF did correlate just on like Pearson's correlation, but did not hold up in multivariate analyses. So overall, initially, this was a little bit surprising because we thought that the typical inflammatory markers that we often measure would be the ones that were high, and we weren't real sure. I wasn't part of the planning, but I don't think they really thought that there was going to be a huge signal, or at least not a stronger signal with the protein carbonyls. But it does raise the question, not necessarily that there's a non-inflammatory or a different process than had been hypothesized, but it may serve as an aggregate measure of different physiologic stressors. So oxidative stress is not specific in any way. It can occur with ischemia, with hyperglycemia, with other toxic metabolic conditions, with inflammation. So it's kind of a end catch-all measure, but it does mean that there is an ongoing process and that it's severe enough to cause carbonylation or oxidation of your proteins, which is an irreversible process leading to degradation of the proteins. So it can lead to significant downstream and pathologic effects. And so, and there have been arguments about white matter being, the white matter abnormalities not being clinically relevant, although it has been shown to correlate with cognitive impairment. But there's an argument, and it's a very valid argument, that it may reflect a legacy effect, because there's also increased correlation with white matter abnormalities with people who had lower nadir CD4s, who have more comorbidities, who have, were very immunosuppressed when they started ART. So there's a question of whether that's what we're seeing, that they had white matter abnormalities when they started ART and nothing has changed, but this argues against that because now we see protein carbonylation is something that is current and it is abnormal and pathologic, and it correlates with these white matter abnormalities. So overall, I think it could be a valuable biomarker, and it was more significant in the blood than in CSF, which is actually awesome because, I mean, the Holy Grail is a beautiful biomarker panel in the blood. So I think it's valuable. And then also interesting, it's not really diagnostic or prognostic, but I put it here. I think it fits. So this was PBR 28 PET imaging or TSPO. So TSPO is a mitochondrial membrane-bound protein that can be targeted with radioligands, and you can then do a PET scan and basically see activated microglia. So it will light up a little bit in everybody, but if you have more inflammation going on, then it will light up more, indicative of increased microglial activation, which is one of the primary, what we think is one of the primary causes of neurocognitive dysfunction and NeuroHIV. So the tech is cool. And then this whole bar graph is pretty small. And that's because I don't want to obsess about it. And part of that was actually Dr. Algoritm's point was these are all comparing to different reference ranges or reference regions. So this is like cerebellum gray matter, this is cerebral white matter, this is cerebellum, this is total gray matter. And these are the same measurements in reference to these different locations. So again, I'm not going to worry about this part down here, but what you can see distilled to the simplest form is one of these is not like the other. And overall, this was looking at 3 groups. 1, controls, HIV negative. 2 was people with HIV who started their ART within 6 months of infection. And then the other was chronic HIV, which is in the red, which was started after, at least 6 months after. And as you can see, the red one tends to be different than the others, which is actually very encouraging because the people who started ART early, there were very few areas where they were different from controls. And they had more similarities with controls than they did with the chronic HIV. So this suggests that starting ART early is good as we thought, but it's may prevent this neuroinflammation that we see. So there are some caveats. So it doesn't necessarily say that it was truly the starting ART early that led to these changes. Because if you look at the duration, if you look at the duration of HIV illness or disease since diagnosis, there's a good difference. 15 years in the chronic versus 3.3 years in the acute infected or early treatment. And similarly, there's 13.3 years on average from the chronic in the chronic group, and there's 3.2. So they've had HIV a lot longer. They've also been on ART a lot longer, even though they technically started later. And this study can't tease out those effects. But in the current CD4, so their current immune status relatively was pretty much the same, but as expected, did have lower CD4 nators between the groups. And I had to check my notes because I was going to say something else. I guess here. So basically, I'm not a neuroradiologist, but my takeaway was, and what she had said was that the TSPO PET imaging is really cool. It can actually measure microglial activation, but the processing of it and interpretation is not standardized. So that needs to be considered if you're reading papers, if you're seeing reports about it, is it matters what they compared to, what the reference region was. And also this does, as I was saying, strongly support starting ART is earlier is better, which we already knew. We've had lots of data for that, but it is pretty awesome. What we didn't know is that possibly it can prevent the significant neuroinflammation that has been seen previously on HIV versus non-HIV patients. And I took out the picture that was in like everybody's poster, and I think has been shown here before as well. But even patients who have HIV but do not have any neurocognitive complaints or neurocognitive impairment still had significant activation of their microglia compared to the HIV negative controls, and was pretty dramatic. So for the people who started ART early to not have that is really cool. But then we have this longer duration of infection and longer duration of ART, which not sure if that's also what's causing it. Not sure if these people who started ART early are going to, in 13 years, whether they're going to look like the people who started ART late, just cumulative effects of the infection and ART. But hoping it's not, and hoping it's because their immune system didn't crash before they started. And then the part that, well, I'm interested in all of it, but I am particularly interested in this part. So there was a lot of talk about the CNS reservoir, and then myeloid versus lymphoid debate, who's causing the most trouble and who's bringing HIV into the CNS and who's making up the reservoir. So we'll talk a little bit. And then I think these are totally just my questions, but I think they were important to kind of frame our reference of what we're thinking about and what is pressing questions in the field and in my mind, and hopefully those are the same. So basically, cure research is going gangbusters and it's looking promising. But we know that there's a CNS reservoir, and we know that it's protected from basically immune, there's the blood-brain barrier. And so it's relatively protected and isolated. So not sure if treatments would get to the CNS. And then secondly, not sure if, because we think that the cellular and molecular mechanisms of infection and the reservoir is different in the CNS, whether the curative treatments that are being tried would even address that reservoir. And so we have to think about whether curative treatments would take care of the CNS reservoir. And if not, could the CNS reservoir then be a source of viral rebound either locally and cause neurological effects, or could it cause treatment failure or cure failure by spreading systemically and reseeding? And then the other part is how much the CNS reservoir is contributing to neuropathology and neurocognitive issues. And if you have a, say, kick and kill type strategy, there's going to be a lot of inflammation. And so there's concern that even if it's brief and short-lived, would a cure therapeutic make this inflammation worse? And is it something that our brains could get over? And then, so brief review of kind of pretty picture and what overall is the mechanism that is thought to happen. So activated astrocytes and perivascular and macrophages injure the blood-brain barrier during acute infection and throughout, but primarily through acute infection. And then the HIV-infected monocytes cross the blood-brain barrier, and they differentiate into perivascular macrophages, release cytotoxic and inflammatory marker or signals, and then that leads to downstream neuronal injury and cognitive impairment. And just a note that there isn't any CSF in this picture. And I will harp on that a bit, but this is talking about blood to brain and blood-brain barrier. And so it is very important for us to keep in mind that brain is different than CSF. So briefly, this was just a good model that just showed overall that what happens. This was a cohort of patients in San Francisco and in Gothenburg, Sweden, from 86 to 2014. And they had paired CSF and blood samples for these patients, and they had them for 3 years. They took the cohort that had 3 years of samples prior to starting ART. And we already knew, viral dynamics in the plasma. We've all seen the pictures and the long-term graphs, but didn't really know what was happening in the CSF. There had been thoughts that there was initial seeding of the reservoir, and then CNS, and then the CSF viral load went down even in the absence of ART. But they didn't see that. So what they saw was basically a pretty perfect correlation between CSF and plasma viral load. It is at least a couple logs lower in the CSF, but that's what we would typically see. But you can see that the line from infection, it's a little bit delayed in the CSF, which we would expect. So it peaks in the plasma, and then it's followed by it becomes detectable in the CSF. And then they really track together after that. And that's up to basically 3 years. They don't change, and the CSF viral load in almost everyone remains detectable. And that is off of medication. So hopefully most of our patients and participants are not having this happen for 3 years, but we know that there is a substantial minority that is. So then,
Katie, it's 8:49.
oh my gosh, really?
Because this is what happens. Yeah. So, and there are a couple of questions, but I don't know if you want to go through one more or two more.
Sure, I'll do a couple more.
Up to you.
Okay, so basically this was SIV infected CD4. So this was a study in monkeys of acute infection, and basically found that there was slightly odd, they weren't even just typical Th1 CD4, but they also had on transcriptome, they looked almost identical to cytotoxic lymphocytes, even closer to CD8s. And those were the ones that were found in the blood, in the blood and in the brain in acute infection. And so it seems the conclusion, I think, is that the cell type that initiates the brain viral reservoir is probably a CTL-like CD4 in a monkey model. And then this was more argument about it's the T cells, not the monocytes. And they did, basically, these are just RNA transcripts. So whether it's viable virus or not, or just proteins, it's any RNA transcript. But they found that the CSF, cell-associated RNA transcripts, was way higher than the PBMCs. And this is in suppressed patients. HIV or viral load was suppressed for, I think, over a year for these patients. And then they had paired CSF and PBMCs. And overall, the biggest thing was there was more RNA transcripts in the CSF, which is somewhat unexpected. There's fewer cells and there's usually a lower viral load. But in these suppressed patients, that was higher. And then in CSF, the CD4 T cells were really highly enriched with susceptible memory cells. So in CSF, 76% of the CD4 cells were memory cells, which is odd. And in the interest of time, I'll skip that part. And I was going to wax poetic about whether this really challenged everything, but I don't think it does. Basically, they say, oh, it's not, throw away the monocyte-centered pathogenic model, but it just tells us that T cells bring the virus to the brain in the monkey model, and that T cells are in the CSF, which is different than causing inflammation and problems. And I will skip this one. Briefly, neurosymptomatic HIV-1 CSF escape. So this is patients who are symptomatic, actually have pleocytosis and have positive or detectable CSF viral loads, and that is a couple logs higher than their plasma viral loads, or their plasma viral load is negative or undetectable. And interestingly, they saw that they were all T cell tropic, which kind of argued against the CNS reservoir being all about myeloid cells. But they also saw that 97% of the escape populations were at least partially resistant to their ART regimen, even though the plasma genotypes hadn't shown that. And that 94% of these patients saw their symptoms resolve after ART optimization, which basically was not even planned optimization, but was just evolving practices. So from switching from PIs to NSTs alone took care of this. So hopefully there's less CSF escape currently. And blah, blah. So basically, I think major take-home points. So we've found that, yes, their early ART is better, which we knew, but this further confirms it. And there has been, concern about the neurotoxicity of ART as well, and if there's balance on that. And it seems pretty convincing that the early ART is better. And that maybe the 2-drug regimens are better than 3-drug regimens, which I didn't initially buy that, but it seems like it might be true. And then CSF does not equal brain. So we need to understand both. I think somehow I skipped it, but basically, I think we need to shift our thinking that the CNS and the CNS reservoir is different compartments. And yes, CSF and brain are contiguous and communicate with one another, but the viral reservoirs and the cells in them and the viral dynamics may be very different between the CSF for the choroid plexus and the brain, and to keep that in mind. And for keeping in mind for HIV cure trials, just want to make sure that it does not cause more injury with all of the inflammation. And then just remember that the immune system is a system. And we still have a lot to learn about the cellular interactions. One of the ones that I skipped was further evidence that T cells and these myeloid cells act as a team. And it's truly the interaction between them that is what we need to know and target. And we can't just try to simplify the immune system down. Okay, that's it.
Thanks, Katie. There was a question earlier on about one of the hand studies that Nettie made. She asked, is the decrease of hand due to the aging out of patients who are diagnosed in the early days? So the cohort is just more enriched with newer diagnoses over time. And these folks may do better due to early, better meds, and earlier in diagnosis due to routine testing, higher naders, et cetera. And then I think Scott made a comment about a study. I'll let maybe Scott talk after you answer that, because it sounds like there are a lot of studies that are going to be going on soon. But yeah, what are your thoughts around that?
Okay, so I think my thoughts are yes and no. Overall, I think, you know, the aging HIV population, as we know, is burgeoning. So there still are a lot of people who still have been infected for 30 plus years and have gone through all of the stuff. But yes, overall, there is some aging out, and there is some of the older people are passing away, and the younger people who start earlier on ART are better off. And it does seem like the rates of impairment are truly lessening due to better treatment, better viral suppression, and earlier ART.
Thanks, Katie. There was also a lot of discussion after I brought up stuff about the exercise study, a few people saying different things. And then Jeff Taylor said the ACTG, I always forget what this stands for, the scientific committee of some kind, has deprioritized any lifestyle intervention trials despite data showing their efficacy in the general population, ensuring that a diabetes prevention program won't get approved, but the GCAP is protesting this, so everyone stay tuned. But obviously that is a big issue. And again, returns to my comment that if we can't even get a program that will likely cost a lot less, trainers at the gym for 6 months seems like a bit of a stretch. Sorry. And then, Scott, would you like to talk for, well, you have a minute. I don't know if you even can. You just brought up lots of studies, and it sounds like, Scott, we're going to have you present soon, but I don't know if you're able to, or if you're just.
Yeah. So hi, I'm just reached my office. So yeah. So anyway, I just was wanting to take the opportunity with Katie saying how cool TISPO PET imaging was to let everyone know we have 2 TISPO PET imaging studies here, and that charter just got renewed, and we're very pleased. It brings $10 million to the university. And in addition to bringing back 200 people who we followed since 2003, we're going to recruit 300 new people. And that includes 100 people who have been infected more recently, because one of the biases of charter is that these are people who've had HIV for 25 or 30 years. And so do the data apply, do the findings apply to more recently infected people? And another group are people who have HIV risk factors, but do not have HIV, because their data showing that they can look pretty similar to people with HIV in terms of cognition and mood and so on. So it furthers the question of, how much of this is truly due to HIV and how much of it is due to the other factors that are syndemic with HIV. So
that's great.
So anyway,
Scott says he'll present if someone can take his ID rotation. So calling all But Scott,
So
we
small,
will.
it's a small price to pay.
I know it's a small price. No, it sounds like there's a lot to talk about. And I think Nettie asked an important question, which you said yes to, which was, could the people at risk for HIV be any agent on PrEP? And you said yes, which is will make that cohort probably easy to enroll. And then it's 9:01. Tyler, you asked a good question, but I think that may have to go offline, and maybe you can ask Katie about it. What effects does smoking have on the brain? And does it explain linkage between COPD and hand? I think that's a great question, but we're gonna have to table it unless Scott, you want to answer fast.
I can quickly say that a lot of people in charter with chronic lung disease actually have asthma, not emphysema, and so it doesn't seem to track as well with smoking. But certainly there are effects of smoking on the brain.
All right, 9:01. Scott, thank you. But Katie, thank you so much. This was such a great review. I think really for those of us who only can attend a few neuro talks, this was such a great summary and highlighted your great work and Scott's and Ron's and David's. And I don't know, I hope I'm not leaving anyone else out. So I'm sorry, maybe Jeff. Anyway, so thank you so much. And everyone have a great weekend. We'll see you next week.
Great job, Dr. Riggs.
Thanks, Dr. Riggs.
Yeah, thank you if I missed your favorite talk, but there was a lot there.
Bye-bye.